Good afternoon. We are coming from across the street, and we're coming with the idea of stimulating your interest for a subject that is sort of coming to full development in cardiology, but is still young and involved in a lot of open discussions in the field. I would like to give you an illustration of what is the logic and the current trend in developing a more mature prevention program for sudden death in athletes. And that is essentially my interest since I have been involved in the study of coronary anomalies for a long time. Eventually, recently, I came to realize that coronary anomalies are actually very frequent the subject of discussion in cases of sudden death in athletes. So let's see if we can go over this presentation that is obviously not complete, but as we have 1 hour a year on the subject, we need to go strictly to the important and interesting aspects of this emerging evidence. The idea or the messages that come to our attention in the general discussion in public arenas or in cardiology can be summarized in these contradicting and confusing messages. Sudden death in athletes is rare and is mysterious, is difficult to understand. Hypertrophic cardiomyopathy are, by decree of a few experts, the most frequent causes of sudden cardiac death in athletes, and the EKG is the way to screen it, and is in 100% of the times adequate. Heat stroke or sickle cell crisis can be more frequent than cardiomyopathies to cause sudden cardiac death. But then there are a lot of other defects, and one of them are called globally coronary anomalies, and all of them are associated with increased risk of sudden cardiac death during exercise. Then the electrophysiologist came with a statement that most of the causes of sudden cardiac death actually are not known or knowable because they are functional and autopsy will not manifest them. At the same time, the public tradition to deal with this problem is to continue to publish and report to the general public the events of sudden cardiac death in athletes. And the conclusion after that is that the best policy to deal with the issue is to just do a history and physical by a general practitioner or his or nurse and hope for the best. And so when we started dealing with this issue and discussions, we had the idea that we could improve, and I will summarize here my story in the field, because I saw immediately an opportunity to grow the specialty and especially to understand what are the mechanisms. That was really what was interesting to me. In the literature, there are several individual cases presented, but very few general discussions, and especially a description of what the causes of sudden cardiac death are in some prospective and structural way of studying. The best study available still is a study published in 2004 by the military doctors, especially here at San Antonio, where there is a tremendous community of doctors involved in the study and prevention of sudden cardiac death in military recruits. They reported at that time a 25 years experience in the U.S. Army is the military, is more than U.S. Army recruits. 23 million recruits. They were followed over the years. As you know, they are kids that go from an unclear background, usually the H&P of a general practitioner as a screening, to very aggressive workload in a 2 months period of selection and basic training. Out of this 23 million over 25 years, the conclusion is that there are 64 causes of death in patients with sudden cardiac death clinically found at autopsy. The mean age of this group is 19 years of age, and as you see here, the coronary death is 61% of the total of 64 cases. The coronary anomalies are 33% of the total causes, or 21 cases. Coronary artery disease is 16%. For an age of 19, the only message is amazing. Already at 19, there are some kids that die of sudden cardiac death from coronary disease acquired and atherosclerotic. A question that needs to be redefined and studied more clearly. Most of these kids had some lesions, some early atherosclerosis, but no sudden total occlusion, no clots. So it's not very clear the cause of death in this, as in many other conditions like hypoplasia. The old pathologists continue to report a small coronary artery as a cause of ischemia and possible sudden cardiac death, a questionable issue. Aneurysms, coronary aneurysm also could be related to sudden cardiac death, especially in case of rupture or clot formation and sudden occlusion. Very rare, but we don't know the details of this. Myocardial bridges. Myocardial bridges can be associated in episode of sudden cardiac death, very rarely with exercise, most commonly at rest, and most commonly with clot formation or severe spasm at the level of the myocardial bridge. As you know, in a general population, autopsy will discover a myocardial bridge in something like 80% of the patients at some level of the circulation. So it's very unclear, the relationship. All of these patients, too, were reported as having no acute myocardial infarction, but only myocardial bridging. On the other side, cardiomyopathies. 23 or 36% of the total 64 cases had myocarditis in 13, 20%. Hypertrophic cardiomyopathy, 13%. Dilated cardiomyopathy, 2%, but obviously this is a very important number. Right ventricular dysplasia, arrhythmogenic in one case, obviously from history more than by the pathology findings. The fact that this was an interesting and objective way to evaluate the type of diseases are in discussion, but opening a question on how to correlate anomalies found in autopsy with the cause-effect relationship that we would like to establish. Eventually, in the last few months, Samuel Jones is from the same group. He is a colonel of the Army that dedicated himself for the last 10 years to the subject. And in March 2015, he updated these numbers. In 2015, he looked at the last 5 years of every active duties U.S. military personnel and found 200 cases in 5 years. That was discussed in front of a large audience and caused a great emotional reaction, and everybody was quite impressed by a number that becomes now more significant in view of more detailed description of the pathology. What we live now in this field is with this guidelines, this basic document on the field from the American Heart Association, American College of Cardiology, organization that quote sort of assume numbers of both the frequency of these events and the causes of death. This is a program that was mainly handled by the group at the Minneapolis Heart Center, where they claim in general that hypertrophic cardiomyopathy is the #1 cause of cardiac death. 36 plus 10% that they call the increased cardiac mass, and 19% are coronary anomalies, then a lot of other conditions. The important data is that that group and that document quoted 0.3% as the incidence of anomalies that can cause sudden cardiac death with exercise in the general population. This is a presumed prevalence. No studies were done ever until we started getting involved with this idea. Our own project was started by a group that is called the Center for Coronary Artery Anomalies, because we were initially more interested in that field. And the philosophy of this, can you go to sleep? Siesta time. The philosophy of this is that basically we would like to understand the denominator. How many people carry these high-risk cardiovascular conditions? In athletes as in non-athletes, to compare one to the other and establish that really this is the mechanism. The circumstances, how many times exercise is related to the actual event, if this is the important feature of sudden cardiac death in athletes. And then to understand the pathophysiological mechanisms of death in these patients with unusual anatomy, and quantifying the risk to establish also the cost efficiency of any generalized program of prevention. So we hypothesized that by establishing with a screening accurate program the prevalence of high-risk cardiovascular condition in school children at the beginning of their exposure to the risk of exercising in competitive sports, we can recognize the candidates to sudden cardiac death during exertion, and the high-risk cardiovascular conditions at this time we would consider are hypertrophic cardiomyopathy, dilated cardiomyopathy, coronary artery anomalies of some kind, and EKG abnormalities, channelopathies, we call them too. On the basis of this, we assume that acting on such identification of the carriers and with an expert evaluation after initial identification of a kind of high-risk cardiovascular anomaly, we could prevent sudden cardiac death in athletes. So at this time, we're in the middle, actually 75% through a collection of 7,000 cases of kids in the general environment, in the schools of HISD, the local school system, where we used a program that is going to be discussed in a minute. In general, this is the reason of why it is important to use this approach of establishing the denominator, because the denominator is to evaluate the people at risk, and at the same time the risk factor for each condition. If we put it as a denominator of a fraction where the prevalence of high-risk cardiovascular conditions of sudden cardiac death are used in the victim of sudden cardiac death in the young. So that's the formula, and an example of this application of this sort of a policy is illustrated here. Left coronary artery is born from the opposite side of the aorta and going through the wall of the aorta becomes constricted and is present in 0.1% of the general population in our group. So it's 1 per 1,000 is an important number. If we compare this to the incidence of the same condition in cases with sudden cardiac death as indicated by the military experience, it compares 0.1% to 33%, so 330 times more frequent in patients with this anomaly than in patients without any high-risk cardiovascular condition. So that ratio is what we proposed, and we're still not sure if the minimal amount of risk should be 10 or 30 or 50 times higher than the general population with a high-risk cardiovascular condition. But that's the method we inaugurated, and we are carrying on by this experience in kids in Houston. Basically, what we are doing is to direct to every single kid that goes to school in the public schooling in Houston, obtain an informed consent or assent for minors, both by the student and the parents, do a simple medical questionnaire, especially for shortness of breath, chest pains, and especially syncopal spells. That is the most frequent predisposing factor in the history of people that eventually suffer sudden cardiac death. A resting pediatric EKG, a simplified screening MRI protocol. This is a protocol with IV, without contrast, without sedation, without beta blocking. It's a very simple protocol that in 15 minutes allows you to see both the coronary arteries in the proximal segments where the coronary anomalies of origin and course is described, and cardiomyopathies, obviously. Then eventually there's an interpretation and a referral of the patient with positive finding to experts, and finally a certification for the people with negative findings or direction of aggressive treatment to people with high-risk conditions. They are disqualified from continuing exercising. This is a report that we made recently in 3,529 in our screening program with an MRI, and we'll see better the population here. In 3,529 cases, we found a prevalence of 1.1 high-risk cardiovascular condition of any kind. This is much higher than what thought before. 0.3 was the assumed prevalence. The anomalous coronary artery of origin with intramural course was 17 cases. Right, more frequent, almost double the left from the opposite side of the aorta. Hypertrophic cardiomyopathy, the mean age here is 14 years of age, is only in 2 or 0.06%. Dilated cardiomyopathy, double. Wall Parkinson of white, prolonged QT. Prolonged QT of more than 460 milliseconds is in 13. But if we assume the most favored definition of high risk only for more than 500 milliseconds, only 2 patients, or 0.06%, will have that kind of a risk. So if we compare the pie with the frequency of different conditions of high risk in the current recommendation of the guidelines, and what we see now in the actual examination of so many kids in the general population at the beginning of their sporting activity, we see that there is a major difference, especially coronary anomalies, the number one condition at this age. Probably hypertrophic cardiomyopathy will become more obvious in the current generation of high school that we're doing when the patients grow up and especially are submitted to a more aggressive plan of sporting activities. In doing the MRI as a screening protocol, we made the simplifications because we wanted to save time. We want to do ideally 3 cases per hour to make this program cost effective and affordable. So we assume that the intramural course of this high risk cardiovascular condition, ACAUS, is related to the passage of a coronary artery that comes from the opposite side at the upper part of the sinotubular portion of the aortic root at the level of the anterior commissure of the aortic valve. And we consider this sign on CTA but also on MRI, where we're going to show it to you. The artery goes across the aortic pulmonary artery, and by these methods you can measure the compression and hypoplasia of this segment. This is a method that allows us to see the coronary anomalies of this kind of high risk in 99.9%, basically in all the patients with this condition. You can see if it is a good quality, and in patients they are not good qualities because of motion, but practically every patient with this condition is seen by an MRI that lasts no more than 15 minutes or 20. The typical image is shown here. This is the aortic root at the level of sinotubular junction. This is the pulmonary artery. The artery that we see here going from this point to the right of the heart in this section goes in front of the anterior commissure and is born in the left sinus of Valsalva. It's an anomalous right coronary artery from the left. The other one is much more risky, is a left that comes from the right sinus of Valsalva. This is the anterior commissure in this case. Basically it's the same projection, and it comes next to the aortic wall. Typically this is called in between aorta and pulmonary artery, but it's actually, as we will see in a cross section in a histology picture, it's all intramural. And this is very consistent reading that we can do easily by trained radiologists, cardiologists in all the patients we have done. In the meantime, we have come to recognize that the complexity of this group of anomalies is much more than what we were told at the beginning. So an anomalous left coming from the right is this typical course, an ostium that comes next to the right coronary artery in the right sinus of Valsalva, comes across at the level of sinotubular junction, passes in front of the anterior commissure of the aortic valve, and gets out of the wall of the aorta at this level where it becomes a normal cross section. But here the artery in this view looks bigger than normal. In a view in the longitudinal direction of this artery, is severely compressed. So there are several different kinds of anomalous left with intramural course. Even a case where the ostium is in the middle of the left sinus of Valsalva, but it goes directly straight down, passing within the wall of the aorta and causing the same kind of severe compression that varies with time, as we will show, and is a new finding in only 2 patients that have been published in the last 10 years.
Dr. Angelini, can I ask a question about that? So, just to be clear, because this is a challenge for us a lot, is that we identify these, right? So, is it required that it goes within an intramural course, or is it there's also a feature sometimes where it just runs in between the pulmonary artery and the aorta, correct?
We will come to that
Okay.
in the next few seconds, but it's a very critical objection or observation. It is not so easy to know if it is intramural aortic or in between aorta pulmonary artery, free in the fat tissue between aorta and pulmonary artery. This is the critical picture that I would like for you to remember all the time when we talk about these Akaus anomalies. A coronary artery at the level of the anterior commissure, this is the attachment of the aortic valve to the aortic wall. This is the aorta, this is the pulmonary artery. The space between aorta and pulmonary artery is full of fat tissue and basically only epicardial soft tissue. But the artery is always, when it has this course at the level of sinotubular junction, it's always intramural aortic. This is media of the aorta. There is no significant intimal thickening in these patients. Even in patients with severe atherosclerosis distally, you will never see atherosclerosis here because there is no intima, no fat deposits, no fat in the adventitia. So this is intramural. It's compressed laterally, so there is a mechanism of both the artery not being able to fully develop into adult size, so there is hypoplasia, and we measure this by the circumference of this cross section. With intravascular ultrasound, you can do it well. With CAT scan or MRI, you have a general idea, and I will show you a picture. Basically, the message is that these arteries are always inside the media of the aorta. The tunica media compresses them in systole and diastole as the aorta enlarges in systole with the normal pulsation of the aorta. There is more stenosis in systole than in diastole. Obviously, this leads to an increased relevance of the stenosis with exercise when the heart rate of a kid in the 200 range yields a systolic time of 70%. So most of the time the patient is more constricted with exercise than at rest. This is the picture by CAT scan that you can show in beautiful 3D reconstruction, but really you don't see the definition. This is the right coronary artery next to the left and the left sinus of Valsalva passing in front of the aorta. With a CAT scan, you don't see the thickness of the media. They give you the inner lumen here and the inner lumen of the coronary artery. It's only in a cross section at this, in a tomographic rendition of this anatomy. If you get a cross section at this level, you will see a definite image of a structure that is compressed laterally, and obviously this is only taken in diastole. The CAT scan gives you a diastolic picture because it's when the image is more stable, and they cannot give you systolic images, and especially with exercise images by CAT scan. But this is the typical picture that gives you a pretty decent marker of severity. We measure the ratio between the longitudinal and transverse diameter of this compressed artery. If it's more than 2:1 or 3:1, there is a correlation with the symptoms. This is in at the level of the sinotubular junction, the artery comes next to the left coronary artery. All this part is intramural, and then it becomes free. This is what, in many cases, but we need to decide in which cases exactly, we can show with an in vivo cross-section of the aorta with much more detail than in CAT scan, in systole, when it's more compressed, and diastole. You see the cross-section of diameter goes from 0.9 to 1.8. The longitudinal is also shrinking. This is even more spectacular. This is an unusual, probably 50% of the cases in which we did optical coherence tomography. We can see systole and diastole. You see that this is more compressed than here with respect to the distal reference diameter. This was a case with 65% stenosis at the level of the worst. And the worst is always very close to the opening into the aorta. The coronary anomaly is more stenotic at the ostium. This is, if you want to take the time and the effort of seeing picture per picture by intravascular ultrasound, we have 30, 20 images per second. So we can build up this curve of the instantaneous cross-sectional area and cross-sectional diameter, short diameter. And we see how obvious is the change in cross-sectional area from 2 square millimeters to 5 square millimeters. Is more than double. And this is what in cross-section will look. If you measure this diameter versus that diameter, we have that kind of variation. So in cases where there is a clinical or instrumental stress test indication for intervention, this is the way we use for coming to a conclusion. And to give you a summary of a long story, this is a summary of our experience in treating with intravascular ultrasound guidance 72 cases that had right from the left and left, only right from the left, where because the symptoms were mild or the stenosis was mild, we preferred to do medical treatment, which is basically beta blocking and reassurance. There is no real treatment for this medically. But basically in these patients, the clinical status was obviously abnormal at the beginning, remains pretty much in the same level. These are functional classes, and severity of stenosis by eye was put together to try to get to consistent groups. So when you have the most serious functional class 5 is when you have syncope typically, and a stenosis of more than 60% in diastole. If you have that, the probability of having a relief of the symptoms of the positive stress testing, it's total in patients with symptoms when you put the stent. This is 26 patients of 36 that were considered to be serious enough as to require treatment. In 26 patients with a stent, none remain functional class 5, none in functional class C, 4 to 6 in severity, and the majority were asymptomatic. So there is a fairly good objective evidence that this is the mechanism, and treating the mechanism with a simple intervention as stenting is effective and explains the condition. This is an interesting picture for the left. The left from the right is more severe, not so much because it's more severe the stenosis, as in this case this is the worst I ever seen in the literature. This is published, it's not in our own experience, but it is at a higher risk condition because most of the heart depends on this artery. The left covers from 50 to 99% of the left ventricle. So ischemia, it's global ischemia if it occurs. This is a typical history too. A female jogger preparing for marathon, a little crazy, had already 2 episodes of syncope. 2 episodes of syncope in Japan, and was reassured because the stress test was negative. And she died suddenly, running in the wilderness, and had this type of anatomic, incredibly severe stenosis with residual lumen of 90% obstructed at rest in autopsy. So let's go to advance the current knowledge that we are trying to pass to the general cardiological literature in terms of pathophysiology of coronary anomaly that can cause sudden death. This is a case, and it's different mechanism. It's not only one, the one we saw before. This is a case of a 46-year-old guy from San Diego that came to see me with a history of severe angina at rest at night, typical of Prinzmetal angina. Even nitroglycerin was effective. He was studied, was called anomalous origin of the left coronary artery. Actually, this is only an LAD. We'll go into the anatomy in a second. And was called to be in between aorta and pulmonary artery, and was scheduled to have surgery in another institution in California, in Stanford. But actually the story was too suggestive of Prinzmetal angina, and the anatomy is not the anatomy of between aorta and pulmonary artery course. This is a coronary artery that doesn't come across at this level, which is the sinotubular junction next to the pulmonary valve, but is going straight down. The first branch off the main trunk is a first septal. We'll see it better in the second picture. And eventually the artery comes out epicardially to give the distal LAD. This is a picture after 100 micrograms of intracoronary acetylcholine. They reproduced amazingly well in 50s. This actually is 50 micrograms. With 50 micrograms, it was very positive with ST elevation, chest pain, shock, and nitroglycerin intracoronary. You need to give it very quickly because, especially when the whole left system depends on this, you are in deep trouble if you don't have an antidote. Obviously, the coronary artery becomes quite bigger, and the spasm is demonstrated in all its relevance. The next is another case that is supposed to be related to a benign coronary anomaly. This also, actually, this touches more this institution. Maybe some of you have seen this case. This came from far away city close to Louisiana, and with a similar story of a patient that with dehydration states would develop chest pain, cold sweating, near syncope. Is a plumber, an industrial electrician. So he was sent with an angiogram similar to this to this hospital to do surgery because this was called in between aorta and pulmonary artery. And again, it's not so difficult to make a diagnosis with a CAT scan as with the coronary angiography. This artery, it's only the circumflex, not the whole left, and it goes behind the aorta. The aorta in this view is the right anterior oblique, or mild the right anterior oblique. The aorta at this level is, or the ostium or the circumflex is coming with the right coronary artery. It goes behind the aortic valve, and the bottom of the aortic valve comes to the AV groove and gives the circumflex. This patient had clinically a suspicion, even though less typical than the previous patient, history of Prinzmetal angina. So we did an acetylcholine test, and this test was dramatic also. The artery almost completely disappears, but what disappears is also this patient doesn't have any other artery than this, and this artery has a large posterior descending that gives all the septals from the back of the heart. The posterior septals give up to the anterior descending territory, and both the circumflex and the right distal artery goes in spasm that completely obliterates the circulation to the left ventricle. Again, AV block, shock, severe pain, everything resolved by giving nitroglycerin intracoronary, and on medical treatment the patient is back to pretty normal life. No surgery is required, and surgery would be very risky. So to conclude, obviously without showing everything that has been produced in the last few years on this subject, but it's such an interesting and stimulating environment that is interesting to see the potential. A left coronary artery that is born in an anomalous site of the aorta can travel to the proper site, to the left normal myocardial territory dependent from the artery in so many different courses: prepulmonic, interseptal, intramural aortic, which is the one that we saw before, intramural aortic, retroaortic, retrocardiac, is at the level of the AV groove at the back of the heart, with the wrap around the apex course, or intraseptal left main, which is a left coronary artery that goes straight down in the septum without coming to the left, goes to the bottom of the septum, and then gives free wall left ventricular branches from the apex. That's an unusual anatomy. I saw one case is published, where in systole the left main is completely obliterated by a muscular bridge effect, and this patient had a syncope. This patient is the son of a doctor and doesn't want to do the full study or any intervention because he thinks that there is a high risk. I had something like 100 syncopal spells in his life for him. It's amazing. But anyway, the prepulmonic case was normally considered to be low risk or no risk and not surgical. But this can cause prince-metal angina. This, by the way, the only good case of this kind is a cardiologist from Arkansas that at the end didn't get relieved by only vasodilators and had the bypass that completely cured the case, but he had a complete occlusion of the left main prepulmonic in systole by history and especially by acetylcholine testing. Intraseptal, the one we saw before, can cause prince-metal angina. Intramural aortic is the one that has fixed stenosis that changes during the cardiac cycle. Retroaortic can cause spasm, as we saw in the other case. Retrocardiac, we never saw any problem of spasm or any other mechanism of fixed stenosis. The wrap around the apex is the one we just saw, and the interseptal is the one we were mentioning of the kid with 100 syncopal spells. At the same time that we do this study, we are reviewing with a forensic center pathologist all the cases that die in Houston and have an autopsy to create a sort of a culture, an objective evidence of the causes of cardiac death. We are not through with this study, but the initial important point is that the right coronary artery comes from the left is even lower than the control population, people that don't die of cardiac death or sudden cardiac death, incidence of right from the left. So we are not through, but on 4,000 autopsies. But that's evidence that most likely the left from the right is high risk, but the right from the left is not a cause of doing surgery that is frequently done in many centers. So this is a study still in production. Let's see if we can make it a little faster to get to the final concept. So what we are ambitious and hopeful is to create a new culture, to establish a new sports cardiology center in our, we are now at the Texas Heart Institute looking for a permanent position. There we do all the studies, and eventually we'll see where we establish the clinical center for sports cardiology. Basically, we are trying to get to this final discipline where we would do screening, clinical evaluation, and establish indication for interventions in only a few patients where we have objective evidence of an important problem, and we are improving the way to treat this condition, especially with the usage of stents in place of necessarily surgery. The basic finding from our MRI-based screening is that there are in the States something like 1.5 million people that have coronary anomalies. They are the most frequent causes of sudden cardiac death at this age in the middle school. So the first important finding was that the prevalence of high-risk cardiovascular conditions is 4 times higher than what was assumed before, 1.1 in place of 0.3% of the general population. And that could be a very good argument to sponsor a generalized screening. We don't promote that kind of policy from the beginning. We want to show that identify the conditions eventually leads to a decreased incidence of sudden cardiac death in the patient at the highest risk. The patients, they are usually male, they do more aggressive competitive sports. Coronary anomalies with intramural course are much more frequent than cardiomyopathies, and 41% of the kids have some kind of anomaly. Hypertrophic cardiomyopathy are much lower in frequency in prevalence at this age, probably will increase dramatically in the next 5 years. And we're now doing the last 2,500 cases, they're all high school. EKG abnormalities are frequent, but if we consider the 500 milliseconds as the high risk level, then it's not so frequent. We never found a single case of arrhythmogenic right ventricular dysplasia by MRI, and in the forensic study there are 2 cases of arrhythmogenic right ventricular dysplasia. So we are now in the process of establishing a new objective evidence-based discipline that I think can change dramatically the interest of doctors in this field and the hope of athletes in pursuing activities that have an intrinsic high risk. Definitely the risk of sudden cardiac death is higher in athletes than in normal kids, but that is related to conditions that we can know and can find out before doing an autopsy.